Okay, good morning. My name is Ashley Weil, and I'm an infectious diseases pharmacist here at Norton, and I'm going to be talking about observational studies. So Dr. Carrico has helped you craft a really excellent research question. So the next step in your journey from idea to publication is to put together that study protocol. With the study protocol, you've got several different elements that Dr. Ramirez has already reviewed, but today I'm going to be focusing on study designs. There's a lot of different study designs with different strengths and weaknesses. But in clinical research, we differentiate oftentimes between interventional and observational studies. And since I'm going to be talking about observational studies, I want to take a moment to make sure we really have a clear understanding of what it means between observational and interventional study designs. So with an interventional study design, you as the investigator are taking an active role in the health and well-being of your participants. In an observational study design, as the investigator, you're playing a passive role with the health and well-being. But just because you're playing a passive role does not mean you're observing them from far or stalking them on the internet. You can still interact with your patients quite a bit. So both designs can involve collecting data, either through medical records or interviews with the patients. You can also perform additional diagnostic or laboratory tests. You can still interact with them. But with an active role as an interventional study, there is an intervention that is designed to treat or prevent a disease that is being administered or controlled by that research team. Whereas with an observational study design, no intervention is being administered by the research team. There might still be an intervention like a drug or a procedure, but it's not being controlled by the investigator. Now, no approach is necessarily better than others. Oftentimes we talk about randomized controlled trials, which are interventional studies as the gold standard in clinical research, but oftentimes these studies are not either feasible or ethical. So a few years ago, there was an outbreak of acute lung injury, not COVID lung injury, but in fact, it was associated with vaping or the use of electronic cigarettes. And although we thought this was associated with a lung injury, the only way we could know for sure is if we were to do a randomized trial, right? Well, of course we can't do that. If we think something is harming people without any benefit, there is no way we can conduct a randomized trial to prove the association between a cause and effect in that way. And so we had to rely on observational studies to examine the association. Now, within observational study designs, there are many different that out there, and I'm going to go through the list of here. In general, as we go from the top to the bottom, the strength of the study design decreases. And with a stronger design, you're more likely to establish that cause and effect relationship. But as I'm going to touch on each of these studies, you realize that one isn't necessarily better than the other. So let's go ahead and start with our cohort studies. Cohort is actually a Roman term that was used to describe a group of soldiers that marched together. So with a cohort study, what we're going to do is look at a group of subjects and follow them over time. So we have many uses for cohort studies where we can figure out the incidence of a condition. Right, if we want to figure out how many people develop lung cancer in the city of Louisville, we can assemble a cohort of adults in Louisville and follow them over a period of time to evaluate the incidence. We can also use cohort studies to describe the natural history or clinical course of a condition. Right now, there's a lot of cohort studies going on to evaluate the natural history of long COVID, right? It's a new disease that we don't fully understand. We don't understand exactly what's happening or why. So the first step would be to assemble a cohort of people with long COVID and observe them over time. So we assemble the cohort, evaluate their predictor variables, follow them through to that, including their outcomes. And lastly, we can use cohort studies to analyze predictor variables for various outcomes. So again, there was once a point in time where we didn't have association that was established between smoking and lung cancer. We could use a cohort study to compare a group of individuals who do smoke, plus or minus drinking coffee, and those who do not smoke, and then follow them forward to assess the incidence of of lung cancer. Now, with cohort studies, we can further break these down as retrospective or prospective cohort studies. With a prospective cohort study, the investigator assembles the cohort, measures their baseline variables, and then they follow them towards the follow-up period, and the outcomes are going to happen in the future. So we get the people together and follow them along into whatever the outcomes may be. With a retrospective cohort study, it's the same idea. We assemble the cohort, we measure their baseline or predictor variables, we follow them through the follow-up period, and then assess their outcomes. But with a retrospective cohort study, all of those events have already happened in the past. Now, this has many advantages using a retrospective cohort study because it's very efficient. Everything's already happened. You don't have to wait for any of the outcomes to occur. But the main disadvantage of doing a retrospective cohort study is that you as the investigator have no control over the quality of the variables that you're able to collect. Right? So oftentimes you're at the mercy of whatever's in the medical record, whatever labs that patient happened to get at that time. You have no control over going back in time and say, can I check your lipids 10 years ago? We can't do that. Similarly, if you're trying to collect data from the patient and it requires them to describe what they've done, you're asking them to attempt to reconstruct the past. And this may not be a great study design either. If you're trying to assess the effect of diet on long-term cardiovascular outcomes, I could barely remember what I ate for lunch yesterday. But if you were to say, hey, can you tell me your dietary habits for the past 10 years? And I'm going to quickly assess to see how that affected your long-term cardiovascular health. You're not going to get a great picture there. So the design is not necessarily always advantageous, although it may be faster. Now with cohort designs, our effects are often reported as relative risk or risk ratio. And this is the probability of an outcome happening in one group versus the probability of an event happening in another. Now, comparing the groups based off of predictor variables might be exposure to a drug or a certain risk factor, but oftentimes you'll see this reported in the literature as RR. Now, the next study design that I'll be talking about might be confused with a retrospective cohort study because this also has occurred in the past. What we're going to talk about is case-controlled studies. With a case-controlled study, again, everything has happened in the past, but instead of starting with a group of patients and seeing what happens to them, we actually start with the end and work our way backwards. So with a case-controlled study, the investigator identifies patients that already have that outcome of interest, which would be your cases. And then they also get a group of patients who do not have that outcome of interest, which would be your control. And then we compare the two groups in terms of possible risk factors. Some strengths of this study design is that they're very good for diseases that have a very long development period or things that happen infrequently, like rare diseases. And they'll also be able to examine a large number of predictor variables in one go, which is really useful for generating more hypotheses. Some of the weaknesses of case-controlled studies is that you're unable to determine incidence or prevalence of a disease. You can only look at one outcome since you have to pick that outcome that have and those that do not have it. And when compared to cohort designs, it is more susceptible to bias. And one of the ways that we can address that, but not necessarily eliminate it, is through the use of matching. So matching is a simple method of ensuring that cases and controls are comparable with respect to major risk factors that are related to the outcome, but not necessarily of interest to the investigator. So what does that mean? Well, I already mentioned to you before, I'm an infectious diseases pharmacist. And one of the things we often look at when it comes to antibiotics is their ability to create or put patients at risk for what's called C. diff or C. difficile. So C. diff is a bacteria that can cause debilitating diarrheal disease. And there are two major risk factors when it comes to C. diff. You have both antibiotic exposure and you have advanced age. So if I wanted to design a case-controlled study where I'm looking at just the antibiotic risk, I want to make sure that I'm also evaluating the patient's age. So in a case-controlled design, I would take cases, which were those that developed diarrhea, and controls, which didn't develop C. diff. And I want to make sure that they're comparable with respect to their age. So all my cases would be matched to an age with a similar, or excuse me, a control with similar age. Now, when it comes to the case-controlled study, we report the effects typically as an odds ratio, which is the odds of an event or disease in the exposed group versus the odds in the non-exposed group. And we used odds ratio as a way to estimate the relative risk since we can't calculate it from a case-controlled study. My next study design that I'm going to touch on briefly is a cross-sectional study. A cross-sectional study, the investigator makes all the measurements for each of the subjects at a single occasion. We get all the information at one point in time. And by doing a cross-sectional study, we can calculate the prevalence of the condition. So prevalence is the number of individuals with a condition divided by the total number of individuals at one point in time. This is different than incidence, and oftentimes people use these terms interchangeably, but they are in fact not. Incidence is the number of individuals who develop a condition divided by the total number of individuals over a period of time. So with a cross-sectional study, since we only have that snapshot, we're only able to estimate prevalence. Now, a common example of prevalence that doesn't even involve clinical research necessarily is the census, right? Every so often, we try to figure out how many people at this point in time are living within our country. But we can also do cross-sectional studies and clinical research. It's a great way to use like surveys or to evaluate population health because we can collect a lot of data. So strengths of cross-sectional design is that they're fast, generally inexpensive. There's no waiting for the outcome to occur since we want to know everything that's happening at one point. And because there's no follow-up period, there's also no patients that have been lost to follow-up. Because of this, we can often repeat cross-sectional studies if needed. However, some weaknesses of this design is that it's very difficult to establish a sequence of events. Since we only know about information at one point in time, we have therefore limited information about the natural history or prognosis of a disease since we only have that snapshot. And because of this, it's very difficult to establish a temporal or causal relationship. Additionally, as I already mentioned, cross-sectional designs do not yield incidence. For incidence, we would have to perform a cohort study, which I mentioned earlier. And lastly, cross-sectional studies are not good for acute or rapidly fatal conditions because you might not be able to capture that at that one point in time. The next design I'm going to touch on is a little bit of a twist to some of these studies we've already talked about, and that is an ecologic study. So what makes ecological studies different is that in these studies, the unit of observation is a population or a community rather than an individual. We've talked a lot about collecting information from an individual patient. With an ecologic study, we're actually describing a patient population as a whole. And a common application of this is to look at geographical correlations between disease incidence or mortality, as well as prevalence of risk factors. So for those of you who do a lot of epidemiology study, you might see these types of ecological studies, like what's the different rates of lung cancer between cities based off of known levels of air pollution, right? So in that study, we're going to be looking at the rates of lung cancer of entire city as a whole. It can be something like what's the transmission rate of COVID-19 between states based off of the presence or absence of a mask mandate. The difference between ecologic studies, again, is just whether or not you're looking at an individual or a group of people. It can be something as small as a neighborhood, or it can be something as large as a country. Another way to, we already mentioned from Dr. Ramirez's presentation this morning, to take advantage of clinical research that's already been done, it's becoming more and more common as healthcare technology is advancing, is the use of database studies. So with database studies, the investigator is able to skip the step of having to perform the study themselves by accessing these large databases. This could be something like your electronic medical record at your organization, or it actually can be some open access study databases that are available for public use. These databases have such large and comprehensive information that you can get this really rich environment to perform studies in that gets you close to real world data. For examples of this, is like the CDC actually publishes much of its work as a de-identified database for public use, if you wanted to find out large population studies. Similar to database design, another way to take advantage of collaborative research is by performing an ancillary study. Now, with an ancillary study, an independent research project can piggyback on top of an ongoing study by accessing their data or their samples in order to extend the knowledge beyond the scope of the original parent study. A common example of this in clinical research would be the use of biorepositories. So an investigator decides to collect information and data and samples on patients with a specific condition. Perhaps you set up a cohort study on patients with long COVID. You gather their information, you follow them along in their clinical course, you collect samples to do your tests on. Now, if you are a basic science researcher who maybe developed an idea that a certain inflammatory marker might be associated with the duration of symptoms in long COVID, you can work with your partner who's done the primary study and say like, hey, I know you've got samples. I know they're sitting there in your biorepository, and I know you've got a lot of data associated with those samples. Can I test my hypothesis that I think patients who have longer symptoms are going to have higher levels of this inflammatory marker? And of course, they'll say, absolutely. I would love to share my information. And this way that researcher can answer their question without having to gather their own cohort, collect all of their data, and do all the sample collection. I think this is a really good example of why collaboration in research is key. Now, last but not least, I do want to talk about case series or case reports. Case series are retrospective descriptive accounts of patients that have interesting characteristics. When we try to observe what associations might be with the cause and effect, it's purely based on clinical observation. There's going to be no statistical tests. There's going to be no p-values. It's going to be pure observation. Case series give us a forum to provide interesting or clinically relevant observations about a new disease or side effect. This case report, or case series that's published here is very interesting because not only is it a case series that was published in New England Journal of Medicine, but this was actually practice-changing publication. So it's a simple report of necrotizing fasciitis, which is a flesh-eating disease, caused by methicillin-resistant Staph aureus, or MRSA. This was published in 2005 and consisted of only 14 patients. But previous to this, it was not common practice for patients that were presenting with community-acquired necrotizing fasciitis to be treated empirically for this bug. So because of this, and because this was put out there, people thought, hey, maybe I should be considering this or altering my practice based off of this simple observation. My point is that we do tend to put a lot of time and attention on randomized, double-blind, placebo-controlled interventional studies, but quality clinical research can be done in something as simple like this. It doesn't take millions of dollars, and it doesn't take 10 years to necessarily change clinical practice. Overall, with observational study designs, I do want to emphasize again that if you as an investigator are playing an observational role and non-interventional role, one of these study designs is going to be appropriate for your study. None of them is necessarily better than the other, and you should really target your study design based off of the question that you are trying to answer. And there is no necessarily one best approach. I have here a lot of small text, so I do believe you'll get a copy of these slides, but what I tried to do is bring you an example of each of the study designs that I talked about here today that's been published in the New England Journal of Medicine, so what we consider the highest tier of clinical medicine out there. And if you have more questions or want to see how these studies were done, how they analyzed their results, how information was reported, take a look at some of these. There's many more examples out there, but oftentimes watching how other people have designed and conducted one of these studies might give you an idea about which study design may be most appropriate for you. And with that, I thank you for your time and attention.